whom we all know, who has really been, I would call him the father of the popularization of non-commercially based dental implant courses, both surgical and restorative here in the UK for practitioners. And he has basically trained two generations, almost three generations now, of people working at a very high level after a very high level course in implant dentistry. Ashok is going to talk to us about complications in maxillary sinus floor augmentation. Please, Ashok.
Thank you. Let me share my screen if I can find it. There we go. Lovely. Thank you. So I'm going to get away from all this esoteric stuff that you guys have been talking about and just focus on a very small part of the jaw as such, and that's the maxillary sinus. And I give this in combination with Thomas, who's observing. Right. So if I can shift this, finding it difficult to. Right. Okay, good. Yes. Historically, we know that it was Hill Tatum that carried out the first of these procedures, and it was published first by Philip Boyne. It has become, in a sense, the most predictable of all the procedures in terms of a site for grafting. A few things that we, in my view, we need to depend upon, and I think we can see this later on in the presentation, is that it's got to be contained within the sinus lining. And I think also we need to have appropriate biomaterials, but mostly we'll see most biomaterials work very well. We need to be able to prevent infection. And as I said earlier, I think the sinus has to have a regenerative capacity. One of our colleagues who's not with us anymore, I'm sorry, who's not a member of this group anymore is Stefan Lundgren, who published the spontaneous ability for bone to form within the sinus just by lifting the sinus lining up and putting an implant in, essentially to tent it up, and he found that bone forms. And the reason I mention that is that, of course, that makes it very predictable. And yet you look at this paper by Peter's group, there was a huge variation between the various publications, between 81 and 96%. And you start to question why this may be the case. And one of the things that hasn't been looked at as closely as it should have been is the systemic conditions, which I'm not going to address, because this is, when you come to things like smoking, there's a lot of data on it which is contradictory. What I thought I would do is I would go through this presentation looking at, first of all, anatomical relationships of this area to other parts of the anatomy, to other parts of the bone. And I would sort of break this up as to into trying to avoid complications, and then, of course, managing complications. And I've decided to split this up into managing them according to the treatment stage. So, for instance, preoperatively, what we can do in cases of infection, as well as intraoperatively when you have a tear, how to manage that. And of course, we do realize that many times infections take place post-operatively as well. What we are aware of is, of course, that there is a very high degree of success rate or survival rate that is presented in many, many papers. So looking at some of the papers that I reviewed, we look at the location and prevalence of sinus septa. We see that about 25% of the sinuses explored had septa. And this is quite significant because we need to be aware of it. And that's where I think 3D imaging, which is a standard now, comes into it, so that we can manage these effectively. Because if we're not able to manage them, then you'll end up with a degree of perforation, a number of perforations that take place. And there's a far higher prevalence of sinusitis in these cases whenever there's a membrane perforation. So I think we need to be aware of that, and we need to recognize that that is a high-risk area. The other area that we come across often in some patients who are partially dentate is the protrusion of the roots into the sinus. This poses a risk, because it's quite challenging to work and lift the sinus around the sinus lining around over the roots without causing a tear. And of course, as with a septum, you can come back, you can flatten it and come back. Here you can't. But what is reassuring is that though there's a high risk of a sinus lining tear, there's very small risk of these teeth becoming devitalized, presumably because the blood supply comes from within the bone. And I don't think that's been explored very much either. So that's one thing. Some of the things that we come across are the extensions of the sinuses. I think that increases again the risk of tears, particularly the medial extensions or the anterior extensions, which come as far as sometimes the central incisor, and just access to these areas becomes very, very challenging. And so I think that increases considerably the risk of tearing the sinus lining. I'm focusing on tearing the sinus lining because I think that's where many of the issues come from. In the same analysis, we saw also that there was pathology present in many of the cases. About 1/5 of the cases had pathology already. And what we are also aware of is that there's a relationship between chronic sinus conditions and postoperative sinusitis. And there's a whole range of material out there. So the incidence is about 21%, which has been reported in the literature. So that's something that we need to be mindful of. There's some straightforward lesions, such a mucocele, which is fairly easy just to go ahead and aspirate. Whether it reoccurs or not remains to be seen, but that allows us the space in which to lift the sinus lining and to be able to place our graft. When you have more extensive, more pathological stuff in the sinus, such as you see here, then of course, it's better to do it as a two-stage procedure, get rid of everything, do your histopathology, and proceed. In those cases where there's a pansinusitis, in other words, the sinuses, several sinuses are expected, then of course what we would like to do then in those cases is just straightforward referral to ENT surgeons, because they have far better access to dealing with these. One of the complications that's also been reported is the loss of the implants into the sinus. And interestingly, this was more common when a crestal approach was taken, things like the Summers technique. And often these things are carried out when it is completely inappropriate to do that. And sinuses and implants have been found in the ethmoidal sinus. It's been found into the anterior cranial fossa, and I have no idea how it would get there, but these are the sort of things that can happen. So losing an implant, I think, is, in my experience, quite unusual, but that is there. We started off, also I mentioned reducing the risk of infection. And I think we should, sinus surgery, and I represent the general dental practitioner here, it should be done under aseptic conditions. And currently, I think the protocol is for the patient to rinse their mouth out with something like Orcidil, chlorhexidine, prior to it, and for us to use antibiotic prophylaxis. We do that even in this day age, an age of MRSA. And what was interesting to note was that when most people carry out sinus lift procedures, they use antibiotics as well as a Corsadil mouthwash. So that was interesting to know. And this is very relevant because of the the incidence of infections that take place after a sinus lift procedure. So I started off by pointing out the number of septa that have been discovered. And it's interesting to see that 44% of all the perforation that took place were associated with septa. And of course, the issue with that is that whether you repair it or not, however you repair it, there is an increased risk of implant failure with this. And if you look at the red bar there, and you can see that the success rate or survival rate of the implants drops drastically to about 74% with these cases whenever there's a perforation. So managing these is quite important, and making a decision as to when to proceed and when not to proceed is equally important. Now, typically, I think what is accepted is that if it's a small perforation being less than 5 millimeters, then that can be managed very easily with some sort of a collagen membrane that can sort of occlude the perforation that you have. And having done that, once you put your graft material in, then I think it's useful to have a post-operative radiograph to make sure that the graft material is contained within the cavity you've created. The smaller tears, between 5 to 10 millimeters or so, I think it's useful to suture them. The best way we found to suture them is to suture the lining to 2 small holes that you make on the labial aspect of the maxilla. And then, of course, you have a cat's cradle going around trying to suture that. And of course, it's necessary in these cases to actually suture it and see that the sinus lining has been repaired, because you can see obviously it moves and the patient moves in and breathes in and out. There's a movement, and that tends to indicate that there's good closure. A membrane can also be used as a supplementary thing here. And of course, there's the use of LPRF is now becoming very popular. There's quite a lot of work being done on that as a method of managing these. I've always been a little cautious in the practice. So whenever we have a large tear, and that sort of in line with the paper that I've just looked at, is we abort the procedure. So it's more than 10 millimeters in size, we abort the procedure. We document exactly where it is. And of course, then we go in and flatten the septum that was responsible for tearing it, so that when we come back in at a second stage, then we reduce the risk of that happening. I normally tend to leave it for about 3 months to everything to heal. And then when we come back, then it becomes a much safer and simpler procedure, because you just reflect your flap up until the edge of the opening that you had made. That's the reason for documenting exactly where it is. And we would often take a second CT scan at this stage. And then you just need to section through the soft tissues and then, of course, carry on as normal. One of the risks that is also reported is that of hemorrhage. And this happens from time to time. And it's invariably due to the blood vessels running through the sort of pneumatized wall of the maxilla, so that it's running often on the inside of the jaw. And avoiding these is sometimes impossible, because actually they're dead right in the middle of where you want to create your window. When this happens, I think what we found is that to control this is just to give them local anesthetic, not to play with that. And I think we get good stoppage of the hemorrhage then. It is possible to cauterize it or use other methods of doing it. whenever I'm suspicious of this, the use of tranexamic acid to stop any post-operative bleeding is very useful, and we use that as a way of controlling it. When you look at, I've explained that I think we all recognize that the sinus is an extremely wonderful place to be able to create bone. And when we look at the biomaterials that are around, I think most biomaterials, as long as they're biocompatible and as long as they change and get converted, that's okay. You can use pretty well everything, and I think there's enough data on that. I do believe that, however, when you have a very pneumatized sinus, such as the one you see here, there is, and it's likely to have very little osteogenic potential, because the sinus line consists mostly of osteoclasts and very few osteoblasts. And in those cases, I think it should be supplemented. Your graft material should be supplemented with the tortuous bone. And this is anecdotal, but I've had a couple of patients that I've treated where we had complete non-conversion of the graft in those cases where there was a very thin remnant bone there. So looking at post-operative complications, of course, we would normally cover our procedures with antibiotics anyway. And if anything occurred relatively soon after that, if there was an infection, then we would carry out a culture and sensitivity and change our antibiotic. In many of the papers I've read, that it's been recommended to continue with antibiotic therapy, but in our practice, we've decided sooner rather than later to evacuate the graft, and then, of course, at a later stage, come back and deal with it. As I've said to you, we've had cases where there's been non-conversion, and in those cases, there's just particulate material there, and that invariably leads to implant failure. You can wait and try again to see if there's any improvement, or you can go in and replace that graft with and include some autogenous bone into that. Of course, moving on now into late postoperative, and that is one of the things that can happen is that the implant can fail. And if an implant fails, you can end up with, of course, a sinusitis resulting from it and an oral-antral communication. And in order to be able to close these, the infection must be controlled, obviously, as we know that. And if it's, again, multiple sinuses are infected, then of course we work with an ENT surgeon to try to control this. Once the infection is under control, then it's fairly straightforward to close that. You just use a connective tissue underlay or parietal rotational flap, because that way we don't lose much of the sulcus as you would with a buccal advancement flap. So that needs to be dealt with. So just to summarize the presentation, we've looked at anatomical relationship, and I think that that is quite important because there are, it is very close to other critical parts of it. Nothing like preventing complications. I think we can all agree on that. And then, of course, managing complications, I think, again, coming into it, if you can identify a potential complication beforehand and manage it, that's an effective way of doing it. Intraoperatively, we've got complications, and we've looked at the different ways of sorting those out. And of course, finally, post-operatively, how one would manage it. I think that's it, folks. I'll sort of kind of stayed within this sort of time limit. I'm happy to answer any questions.
Thank you very much, Ashok, for a great overview. Any questions?
I have a question. Ashok,
Stephen, where are you?
Can you see me?
Yes, you're there. Yes.
if you said the only type of cells that are bone-like cells are osteoclast in the membrane,
Yeah.
then how would you explain Stefan's ability to just elevate the membrane and cause bone to form? So
Okay, so thank you. Interesting question. I was referring only to, I mean, when you have a large, I was referring to those sinuses that are pneumatized, and there's a very thin eggshell sort of kind of amount of bone remaining. If there is more bone, then of course, then you have the regenerative capacity coming from that. And these are just my thoughts based on my experiences, where we've had issues with those very thin eggshell type sinuses where the tissues where the bone hasn't converted when we've used just a biomaterial without any autogenous bone. So that's where this thought comes from. I'd be very happy to have other people's thoughts on it as well.
Hendrik, do you want to comment on that? You know Stefan's theories, you know his
concentrated on my presentation. Yes. No, I agree with everything what was said. It's okay. Yeah.
Any other question?
I have a question with regards to experience about going back in after a not necessarily a failed sinus lift, but an aborted sinus lift because of perforation. My experience when I've gone into sinuses where there's been a disruption of the membrane, I often find that you go back in and there's the membrane is not complete. There's still a defect in the membrane. I don't know if that's anybody else's experience.
It's actually very, very interesting. You mentioned that, Jason, because we remove a lot of the sinus lining away and flatten the septum. And in some of the cases when we've gone back in, you've had de novo bone forming from the floor. So in fact, the sinuses, the size has diminished considerably, and the walls are thicker. We didn't have much time on this presentation, but that's been fascinating. In the cases that we've gone in, we've always had sinus lining develop, but then again, we've left it for a period of 3 months before we've gone back in. I don't know whether anybody else has experienced sinus lining not forming.
Ashok, there was a time, I think, that for most procedures you preferred bone grafts, bone blocks, rather than biomaterials, maybe not for the sinuses. You say that for these K-Wood type 6 posterior maxillary resorptions with an eggshell nasal floor, you would use a mixture of bone and biomaterials.
Yes.
One question, I presume these are bone scrapings. Second question, do you still see indications for using bone only in sinus lifts?
That's very interesting. For the class 6 type cases where the entire maxilla is involved, then we would probably be reconstructing that from the iliac crest anyway. So we have a fair amount of cancellous bone. But I would always mix that with the biomaterial because the cancellous bone on its own resorbs very fast. Okay. Of course, this is all patient-centered, so patients are an integral part of this. And there are patients who choose not to have anything synthetic, and they prefer their own bone, in which case we will harvest, let's say, a piece of bone from the ramus, and we will put that block in and put it in either I've done it with an implant at the same time, or with a screw to keep it in place. And I've done that. But in the majority of the cases, the stability that some of the biomaterials, some of the xenografts offer us is very good, because as time goes on, you see very few changes in the volume. Whenever we've used just cancellous bone, it resorbs very rapidly, and we've had the tenting of the bone over the implants.